Hello, I'm Dr. Laukinen, and thanks for joining me. I'm going to talk about how we approach breast cancer when there's a PALB2 gene mutation. And if you're watching this as preparation for an appointment with me, I very much look forward to your visit. So, what is PALB2? A gene that affects your risk of breast cancer. And the idea is that if you have this gene mutation, your lifetime risk of breast cancer might be increased to some number above 30%. Some people quote about 45%, but if you drill down, it depends on the individual context, the family history. Might be 30% if you have no family history, but up to 60% if you have, say, uh, two or more relatives, close relatives that had breast cancer that was found before they were age 50. But as a rough rule of thumb, we might say that having this specific gene mutation might increase the risk, say, three to fourfold above the average population risk. And uh, as you know, that unfortunately is moderate. It's perhaps 11 or 12%. So people have looked at the PALB2 mutations in breast cancer risk over the last 10 years or so, but there's still a lot to be learned about it. So, why does a problem with PALB2 affect cancer risk? The idea is that genes have a job, and the PALB2 job is to uh, repair damage to the genetic machinery that can lead to cancer. So, PALB2 enables uh, the tumors that they're trying to develop to be suppressed. And as you might imagine, that if there's a mutation, so it doesn't work properly, those repairs aren't being done properly, cancer is more likely to arise. And the better known gene variants are the BRCA1 or BRCA2. And the risk associated with PALB2 mutation is what's called a moderate risk, and it's somewhat similar to BRCA2. Uh, it might be a little bit lower, and it's perhaps not surprising that there'd be some similarity because, in fact, the PALB2 and the BRCA2 genes they sort of work together. And even when we look at the name PALB2, PALB2 stands for partner and localizer for BRCA2. So, how to manage the cancer risk that's associated with PALB2 when a breast cancer has been found. And a person may be found to have breast cancer, have genetic testing, and this gene mutation is found. And there are two broad choices. One is to say, well, let's remove as much breast tissue as possible, that the a mastectomy for the cancer that's found as treatment for that, and perhaps a prophylactic mastectomy on the other side, and potentially with some form of reconstruction. And the other approach is that the breast is preserved, that the cancer is removed, but then there's careful future surveillance. And how to make those choices? Well, individual preferences are important, and the information that a person works with and any bias in the environment is important. For example, in one study where people were um, learned that they had a PALB2 mutation, about a quarter chose breast preservation, and three-quarters, in fact, chose the mastectomy approach. But those proportions could vary in any small group of people, maybe half and half, and so forth. And when we look at how to choose, it can be helpful to compare the outcomes of those choices. And the kind of key outcomes that we would be interested in are, well, what is the local recurrence rate in the long term in the affected breast? Or what is the probability of cancer rise in the other breast? And importantly, what is the impact of any of that choice on what's really important is survival? Other things to consider are how an individual might feel in terms of body image, quality of life with breast preservation versus mastectomy. And then, of course, actually undergoing the procedures. On one hand, breast preservation associated with often a course of radiation treatment to the breast, And the major breast surgery, uh, especially bilateral mastectomies with reconstruction, is a fairly big job. So, what we have learned is that for people that have breast cancer and a Palb2 mutation, a mastectomy is not a clearly better choice over breast conservation when we look at, for example, that overall survival or the long-term local control. And so there's all kinds of official bodies that have looked at the evidence, and admittedly, it's not a huge body of evidence, but the general idea is that mastectomy is an option and breast conservation is an option, and that either of those choices is not going to compromise the key feature of, say, being alive 10 years down the road. And in fact, this is what's been seen with the BRCA variants that are more studied. And the idea is that people can choose breast conservation with the BRCA, but they need to have careful surveillance. They need to potentially anticipate that they could have another breast event in the future. Now, what about the local recurrence rate in the breast? If a person chooses breast conservation surgery and radiation, there aren't really precise figures based on large populations, but maybe a rough rule of thumb might be if we look 10 years down the road, a person might look at a 10 to 15% local recurrence rate. You might say, how does that compare with people that don't have this mutation, that have breast conservation and radiation? So there's a range of local recurrence rates at 10 years, but they can be as low as 2 or 3%, and they can be as high as 5%. They're typically not at the 10 to 15% range. So how does one make a choice between two reasonable options? Well, one looks to oneself and says, what are my personal risk preferences? If a person says, I absolutely want to have the very lowest chance of looking at any cancer possibility down the road, and I don't mind having pretty big mastectomy surgery and reconstructions. I think my body image is going to be just fine with that, and I think I can get through the bother of big surgery. Um, that can promote the mastectomy approach. If a person, on the other hand, says, "Well, I know that breast conservation is it's a recognized thing to do, it's a reasonable thing to do, that it's in the short term, it's absolutely a much simpler thing to do for the average person, and I have the benefit, and it's important to me to have the normal native breast tissue as long as and as naturally as I can. And I'm okay with having a set of checkups. And if I'm in that 10 or 15%, in whom at 10 years I have to deal with something, I can deal with it then. But hey, I'm going to look at it more optimistically and say, I'm going to be in that 85 or 90% that doesn't have an issue at that time. And for that person, the breast conservation radiation approach is a very, very reasonable one. So